Dear friends, as usual, we have just started broadcasting. In 5 minutes, our friends will be joining, and we'll start sharp at 7:05. So please wait till 7:05. So, dear friends, welcome back to our webinar again. So, today we have an intensivist from UK joining with us, Dr. Sudhindra. Dr. Sudhindra, we know him for almost the last 13 years or so. Uh, he was just junior to Dr. Sanish, and he was 2 years senior to me during our MD days in Kasturba Medical College, Mangalore. So after completing his MD from KMC, he shifted to UK. He underwent training both in anesthesiology and in intensive care medicine, got accredited in both specialities, and now he is working in UK, and he is in charge of ICU training in his hospital. And again, he is a runner, and he love traveling, and he's a mridangam expert as well. So today, like he's having a like extensive experience in treating COVID patients. So today we would like to hear from Sudhindra, like what is his experience in treating COVID patients, how they've like transformed their unit for accommodating COVID patients, and how they train the like their staff to treat COVID patients, and again what are the treatment policies they are adopting. So over to Dr. Sudhindra.
Uh, Thank you, Anup and Sanish. Thank you for your kind words. And it's nice to interact with you all and get back to our old memories of KMC. So without much ado, I'll get on with my presentation. So I would just want to say that I want to greet you all the attendees who have come to this webinar. So all I want to tell you is that I'm going to share my experience. It's been an unprecedented state of affairs for the last 2 months. Life has changed quite a bit. So I'll just talk about my experience, certain bit of evidence of what is what, and also what our practice and how it has changed. So I'll just start my presentation. So that's me. I'm a consultant at Lancashire Teaching Hospitals. This is in the northwest of the United Kingdom. It's a tertiary trauma center, and we are a major center for vascular, upper GI, colorectal, and also apart from tertiary cardiac, we have pretty much everything that we do at our unit. So with regards to the actual start of the presentation itself, I just feel that the whole shift in the process has been towards something which will be a new normal. Now, by this, what I mean is that we probably have to change our mindset, our whole thinking process in assimilating the information that has come through in the last couple of months, that there is a change in the life, and life has changed to what would be not necessarily for the next few months, but for perhaps the next few years and for the decades to come. I think that's something we need to reflect on going away, not just today, but over the next few months to years. So that's me. Despite all the stressors and everything, we do have to keep smiling. That's the safety zone. The secretaries in ICU wouldn't let you anywhere close to you. You'd have to stand in the box and ask for what you have to do. But keep smiling and keep going forward is what is the motto. So that's my wife and my kids. So thankfully they bear me. I'm not divorced. I'm happily married, and they take care of me, and I take care of them. So that's a very important asset and core principle to have if you have to work in stressful environment and come home for something which you would want to love for. So coming to conflicts of interest, I have none. As I said, my talk is partly based on evidence and partly based on my personal experience. And today's evidence, what might be there today, might be something which is going to change tomorrow. I tell this because there are so much papers. If you look at what is in JAMA, if you look at Lancet or New England Journal, what is coming today might be something which might be changed or tweaked, or it might evolve into something tomorrow. So we need to take what in the current pandemic era as evidence as it comes with a bit of caution. And as we are here, we are still understanding the pathophysiology of this disease process, and we are trying to understand what needs to be done. So just to give you a perspective of what we went through, I mean, the first case in the United Kingdom was reported on the 29th of January. And following that, if you look in a month, in 3 months and 7 days, we are up to 200,000. We are up to over 200,000. And if you look at the number of deaths, we have crossed 30,000 yesterday. So we also have the notorious distinction now of having the highest number of deaths in the entire Europe. I mean, if you take UK to be a part of the European Union, the Brexit has happened, but if you still think the UK is a part of it, we have taken over Italy for the highest number of deaths. And with that comes the lockdown, with the staying at home, staying safe slogan, which to some extent has helped in plateauing the curve, but still we do see unprecedented number of cases on a daily basis. And with this comes the huge burden of the economic aspects as well, not just from a healthcare perspective, but also the entire economy of the country and globally as well. So just to sort of give you a perspective of what happened in our ICU and what we went about doing, I think it's just to give a bit of an organizational shakeup that had to happen, given that we were preparing ourselves for this surge and for the unexpected increase in the numbers. So it not necessarily happened nationally, but also regionally. So we have a network called as the Lancashire and South Cumbria intensive care network. So we had broader discussions with the ICUs all across, and with the medical directors and clinical directors, we looked at what our capacity is. So if it's a 40-bedded ICU, can we scale it up to 5 times? So 200 beds, level 3 patients. So ventilators, equipment, personnel, logistics, all of this. So we had to find out where our theater ventilators are, where the anesthetic machine ventilators are, where the day case ventilators are, where the portable ventilators are, and we had to give a number as to how much we can scale this up to. That is, I think, one of the most important things to be done, and in any kind of a pandemic, to kind of scale what's the maximum extent of your operations are going to be. And equally, you need to have a local escalation policy as well. So how is it going to be escalated in terms of, if you're hit with 30 patients, how are you going to have a standard operating procedure to put them in which part of the hospital and where? So the entire hospital was split into red, amber, and green zones. So the red is for the positive patients, amber is for patients who are having a test but are awaiting for the results, and the green zone is for very low risk and who are negative patients. We also ended up stopping all elective activity, and there was a huge shakeup in the rostering of the consultants, trainees, nurses, and allied healthcare professionals, just so that we can kind of cope to the huge pressure in the surge of the cases that we were getting. So it all happened even before we were at any form of a peak of activity. We also had a huge amount of input from a national guideline. What is important is, if everyone speaks through the same hymn sheet, and if everyone follows one particular core basic principle, it becomes a lot easier and there's no confusion. So Department of Health sent a very clear donning and doffing document, which we all followed. And there were multiple sessions where everyone who had to be working in the hospital had to go through a mandatory training for donning and doffing. So that was something very rigorously practiced. We also had simulation training. There's a health academy with a lot of simulation stuff. So we involved them, and I got quite heavily involved as well, to do simulation about a patient comes to the accident and emergency department. How do you initially assess this patient? And if the patient becomes quite unwell, what is the way of getting this patient safely to the ICU or theaters to the shortest, safest route possible with minimal contamination as possible? So all of these simulation trainings, along with airway management, was quite heavily drilled into a lot of our heads, and it did help when the real cases came. So we were a bit more subconsciously prepared for this. Apart from that, if you also look into the future planning from what you're doing. So if at the end of each day we used to have, I'm left with 2 amber beds, I'm left with 2 red beds. So what is my next escalation? Which ward am I going to go? If I'm exhausted from theater, ICU, I'm going into theater recovery. I'm going into theaters. I'm going into neurosurgical wards. I'm going into vascular wards. So we had a clear policy of which wards would get emptied and where we would be going. That's what we did. With regards to the testing, a very brief mention I need to make is the thresholds have changed from the time when we initially started. The most obvious now is any patient who's symptomatic, who's got continuous cough, who's got sore throat, and has got temperature will get tested. But the practice in the UK is that if you're not symptomatic, you stay at home. If you are symptomatic, you call 111 and take advice. If you're really unwell, you call the ambulance, you come into the hospital, and then in the accident and emergency department, you get triaged depending on how clinically unwell you are, either to go into the acute medical unit, or you go to the respiratory ward where you get non-invasive form of ventilation, or if you're really poorly, then you get called by the ICU team, who come and review you and will take you straight to the intensive care unit. So that's how our triage system works. They all get nose and throat swabs, but the sensitivity of it is variable depending on which paper you code. So we make sure that anyone who comes to the intensive care unit also has sputum samples sent. And if they do get intubated, we also send non-directed bowel through suction traps. So apart from that, we also need to look at what are the guidelines for admission. So as I've mentioned, there needs to be very close integration between different departments as to who goes to which ward. Again, these are fluid, these are not arbitrary, so it all depends on the patient's clinical picture. So if someone is heaving away, has got increased work of breathing, and who clearly is going to tire and fatigue, will be making their way to ICU rather than going to a medical ward and then to deteriorate and then be called. So someone who's stable enough, who's on 40% oxygen, who can go on to a CPAP hood or other non-invasive means, will go to the respiratory ward. So every morning we have an input from the medical and the respiratory take, and they give us an idea of who is potentially unwell and who needs to come down to ICU. With regards to ICU escalation as well, we have a clear plan in which patients' comorbidities, the frailty status, the reversibility of the pathology, and their rehab potential is also very clearly elucidated before a patient comes down to the ICU. So this is something which we need to look at based on your resource utilization as well. Because if you flood your ICU with patients who potentially are not going to be making much of a meaningful recovery, then I think you are early. Then you're looking at a lot of your resources being utilized very early in your course of a pandemic. So you need to be quite careful about it. And once they are on the unit, if they have spent their time and if they've turned into green from red, you also need to look at where the flow happens and which part of the hospital they will be stepped down. So that's something which you need to think about. And bearing in mind, as an intensivist and as an anesthetist, you also have to look at your other business as usual. I mean, you have your bread and butter cases that come through. Yes, it's a COVID era, but trauma can happen. Of course, with the lockdown, there might be much lesser. Neurosurgical patients can come, vascular patients. So you need to be sure that you also have a green bay, which is also dedicated to your general intensive care patients. So that's something which you need to have, bearing in mind that these patients also need to be put into the ICU as and when they come in. So coming to guidelines and therapies, we need to have some kind of guidelines done, not necessarily which is very, very evidence based in the initial part of the pandemic, but you need to have some structure as to what you're going to be doing. The reason why I tell you is that you need to have some kind of proning or intubation teams, because if you have 16 or 20 patients who need to be proned on a daily basis, depending on your numbers, if you use your ICU staff and you as an ICU consultant end up doing all the manual labor, then I think your fatigue and your cognitive burden becomes quite a lot. I mean, so you need to have teams. We involved orthopedics, general surgeons who are a part of a proning team. They went through a drill and they were trained to prone patients, and an anesthetist would take care of the airway, and the rest of the 6 other members would be non-ICU, non-anesthetics people who would be helping with the proning. Same way, we had an intubation team led by an anesthetist. Again, we were quite hands-off and we led them to do that bit. So everything was quite streamlined so that we could have some kind of hand back from our own priorities of dealing with these patients rather than physically getting involved in proning and intubation and so on. Of course, if it was an emergency, we would have to do it, but we had teams for this. And with regards to mechanical ventilation as well, you need to also understand that these patients can be in different phases of their disease process. So when they present quite early in their disease process, they could be the L phenotype, as you're all probably aware of, when their elastance is low and they perhaps don't have much of recruitable lung tissue, and your X-ray arguably or the CT scan will look with a few ground glass changes, no major changes. But when they go into the indolent or the H, further progressing into the H phenotype, that's when you have a full-blown arch picture where there can be recruitable lung tissue as well. So you need to be sure that you do lung protective ventilation. The mode which you chose, I'm not going to go into that. It's a bit sticky. We use a fair amount of APRV, but any mode, as long as you limit your plateau pressures to less than 30 and your tidal volume to 6 mils per kilo, then it should be acceptable, I would say. I mean, that's what we have agreed as a group of consultants. It's quite important to understand heart-lung interactions. This is a very significant disease where I feel that bedside ultrasound is really useful, especially because of the perfusion problems that you come across early in the disease with the microvascular emboli, and also to a fair extent macrovascular emboli. I think it's worth having their heart and lung ultrasound done fairly regularly to see how best you can either fluid manage these patients, and also to see if there is a need for them to have an earlier CTPA. I'll come to that in detail. Um, Renal replacement is another important point. About 30 to 40% of our patients, and in general across the globe as well, there is a pretty much similar percentage of patients who end up needing renal replacement therapy. So that's something which you need to look into as well. Anticoagulation is a big topic. I'll come to that more in detail towards the end about what we have agreed. But it is a big problem, and you need to have some kind of a local agreement about what kind of anticoagulation modality you would be using for what triggers. Um, I put rationalizing and reducing sedation importantly here because uh, imagine if you have 50 or 50, 60 ventilated patients who have been sedated to a RASS of -4 or -5, depending on how unwell they are. So if you're running them on heavy infusions, you need to have a chat with your pharmacy, with your stockist to see what is your store of sedative medications. So we get a weekly update from our lead pharmacist, right? We have this much of propofol, this much of midazolam left out. So we have now started using early enteral long-acting benzos and opioids to reduce our infusion rates. I think that's something worthwhile thinking about, because if you're hit by a second surge and if you have a massive number of cases who are on the ventilator, you need to start thinking of what other sedation modalities need to be used to preserve some of your sedatives. Simple thing is when US was hit by the big surge, uh, pretty much US monopolized almost all of the propofol that was available. So that's why we suddenly had a big shortage. I'm not sure how it was across in the East, but we had to switch over to midazolam as a part of our first line than propofol. So just something worth thinking and remembering. So I'll just come to a bit of a clinical aspects of what generally happens on a COVID ICU. I'm sure you all have your means of working, but I'll just talk you through of my experience and how we do it. That's me, by the way, in all those pictures. And on a typical day in the morning, we come in, all of us are in scrubs. The morning handover happens by the night team. There's a sit down handover again with a social distance maintained. That particular area gets handed over to that particular consultant. And we also have an appropriate airway person apart from the consultant who will be in charge of that area, especially if you have prone patients. We then have a team huddle where we, along with the nursing in charge, find out who's the sickest patient, what needs to be done first as a priority. So that's done after the handover happens. And before we go in, it's very important to have all your electronic patient records quite extensively reviewed, because if you're in there in your PPE, in that hot, sweaty environment, you just wouldn't want to stay in for very long unless it's absolutely necessary. Okay, so you need to make sure you have a good overview of your patient, have a good summary, have a plan of what you want to do, except for doing dynamic fluid assessment and changing your vent settings and perhaps writing up some medications that you need to. You shouldn't really be unnecessarily spending a lot of time inside the COVID ICU. That's what we strongly adhere to. So majority of the assessments are done outside, and we look at that in great detail. So that takes a fair amount of time. And then following that, it's absolutely necessary to have utmost precaution while you're donning and doffing. Following that, we also make a review of what equipment that needs to be taken in. If someone needs a central line, someone needs a VAS cap, or there is a patient on CPAP who needs to be intubated. So all the necessary kit box that we have a trolley for will be made ready before it's actually going in, so that we don't keep asking for, oh, can I get this, can I get that, from once you're inside. So that needs to be, again, organized before you go in. We have pre-populated drug charts. So pretty much all the PRN medications and all the infusions are already prescribed. once the patient comes in, that is already done. So we don't have the drug chart to come in back and forth. So if anything's needed, it's done once it's in there. So again, when the patient gets intubated, they also get an NG tube and a left-sided central line. We'll spare the right side if needed for VAS cap. So that becomes as a part of the routine for any patient who gets intubated. And as much as there are emergencies for proning patients, we do tend to have our majority pronings done by late afternoon as permitted, because that will give you that 16-hour window so that they can be deproned the next morning. I'm talking about 15, 20 patients in different areas. What you don't want is 2 patients proned in one place, 2 in another place, and 1 hour apart, and it'll all become very confusing. So we have a proning team that comes, and we try to as much organized as possible for them to do it in one go, so that it all can be synced and done better for the next morning. So that's in brief an overview of what happens on a COVID ICU in a day. And I can't emphasize how much it is important for you to have perhaps a machine which is dedicated to the red zone. I think having your 3 probes over there, one for your vascular access, curvilinear probe for your lung ultrasound, and for your echo probe, it's a very good tool to have in your COVID ICU. So we do not use routine radiology as a diagnostic tool. Again, it's more if in case you need to identify pulmonary embolus and so on from a CTPA point of view. But as far as the lung ultrasound is concerned, the 2 most common patterns that you can see is, I mean, certainly what I have seen is if you have extensive B lines with skip lesions and pleural thickening, these are the ones who potentially can go on for having incremental PEEP, and you can find out what is your ideal PEEP. Whereas the ones who have normal or small consolidation changes in your anterior lung field, and then posterolateral changes are quite extensive, then these patients probably benefit from very early proning. So that's one thing which I have, as a pattern recognition, found out. It also helps you in having a fair amount of extravascular lung water, and it can guide your fluid therapy. As far as echo, again, I'm sure you all are aware, it gives you a fair idea of your LV-RV function, filling status. The RV strain needs to be taken with a pinch of salt, because again, with ARDS, you could have a certain degree of strain. What we tend to, I'll come in the thromboembolism bits of it, but we have started to do CTPAs fairly early in these patients, because almost 70% of these patients have some kind of segmental, subsegmental PE, or they have ended up with even saddle thrombus as well. We've had a couple of patients who've had saddle thrombi. I mean, surprising that they survived with having a saddle, but they are very, very prothrombotic. So a threshold for performing a pulmonary angiography has changed quite a lot in the last 2 weeks. Coming to the fluid management, again, I'll just keep a very brief overview of it. I think it's very useful to have bedside fluid assessment. Of course, you can do the bedside assessments in terms of your passive leg raise. As I mentioned, you can do the lung ultrasound. Sometimes you use the pulse counter analysis in some patients to see whether there is a distributive shock along with the element of them having some kind of myocarditis as well. So it depends on what your setup is. But what I need to emphasize here is, in the early stage of the disease, if the patients come in being very dry, very possibly intravascularly dry, in those patients with perfusion problem being the early part of the process, they might benefit from fluid to be administered. Whereas in the latter part of the disease, when ARDS has been fully set in, you might need to be quite fluid restrictive. So with regards to renal replacement, just as I was mentioning, there are multiple factors. The disease process itself, with a lot of inflammatory mediators, patients who have got comorbidities which have got worse as a result of the disease, your ventilator settings, change in the renal perfusion pressure as a consequence of that. So lots of reasons can be taken for why they can have worsening of their kidney functions. Our incidence is anywhere between 30 to 40%. initially, again, we are probably guilty of using aggressive diuretic therapy. Perhaps that's what it was with many of the initial part of the treatment regime that came through. But now we are very cautious about running patients in a negative balance. We either go for a euvolemic or a slightly positive balance. So another important thing to mention about renal replacement is you need to also have a fair idea, if you've got lots of patients who end up with needing renal replacement, about your disposables, about your procurement, and whether your plumbing is enough to take care of patients who might, many of them might need renal replacement. So just something to think about, because we have had inputs from few of our sister institutions where they have run out of disposable CVVH kit. And since we also dialyze on ICU, we have had stable patients who have been transferred across with renal replacement being needed. So as I was mentioning, the sedation and analgesia, it's quite important to have different first line, second line, third line strategy, so that you can have a backup if you have shortage of drugs. Now, as I was mentioning, we have started relying on boluses of long-acting sedative agents. It also not necessarily helps in reducing your infusions, but it also sets a precedent for you to start the weaning as well. So we have got a guideline in which you can start reducing your midaz infusion once you have got diazepam on board. We also have oxynorm and morphine sulfate. Once that is on board, you can start coming down on your alfentanil infusion and so on. So it's just something to have an idea of how you would bring down your sedation, especially if you are using unfamiliar sedative agents. If you're in a surge, this is what our experience has been. And also equally of note, with a lot of use of sedation and benzos, you are also running a risk of delirium in these patients, significant increase in the incidence of delirium. So coming to VTE, as I was mentioning before, there is a huge evidence base now in the current pandemic context. I would say that there is definitely microthrombi in COVID patients, and also there's increased translation of that into poor clinical outcome. So what we did is we had a look at the Intensive Care Society guidelines and the respiratory British Thoracic Society guidelines and the hematology guidelines, and locally we formed a group in which we had intensivists, hematologists, respiratory consultants, renal physicians, acute medics, and general surgeons to come up with an idea of how we can agree on what would be the appropriate dose and what would be the trigger to put them on a certain dose. So off note, I think the take-home message here is we have started using what is called as a high-dose prophylactic low molecular weight heparin, which is basically double the dose of your standard prophylactic dose. So based on their weight, simply if I were to give you an example of what we are doing, less than 50 kilos, 2,500 units of dolteparin. 50 to 100 kilos, 5,000 units. 100 to 150, 7,500. More than 150 kilos, 10,000 unit OD. So all of this will be doubled when we are going for the high dose prophylactic low molecular weight heparin. So I'll just show you a flow chart. So I don't know if it comes out quite clearly for you all. What I'm showing here is, if you have someone who's confirmed or even is a suspected COVID, because as I said, if the swabs are sent and if the sputum samples are weighted, but clinically they are showing signs of being positive, then you will start looking at, are they requiring supplemental oxygen? Are they requiring CPAP? And also you start looking at some biochemical parameters. So you look at the D-dimer. Again, D-dimer troponin in isolation as a single value is a little skeptical in terms of whether we should be just going with that with the high dose. But what we agreed with hematologists is, if they need supplemental oxygen, if they are on CPAP, and as a biochemical supporting evidence, you have the D-dimers are also raised, then we are very comfortable to go on this high dose prophylactic low molecular weight heparin. Obviously, you'll have to look for the routine contraindications. And Once you have done that, you can keep them on that particular dose if there are no worsening symptoms. So perhaps majority of these patients who don't go on to be on the ventilator or just need non-invasive treatment regimes then get better. And if they don't need any oxygen, then they can be stepped down to the standard low molecular weight heparin. However, if their clinical condition worsens, or if you clinically suspect they probably have a PE or there's disproportionately increased oxygen requirements, then you'll have to start thinking, am I going to increase this high dose to a therapeutic enoxaparin dose or a therapeutic anticoagulation? So which is what we are doing, bearing in mind, very importantly, at the earliest opportunity for you to get a CT pulmonary angiography, that needs to be done. So that is what we have agreed upon. You can, as a clinical decision and as a group of consultants, increase that high prophylactic dose to therapeutic enoxaparin. But if you have a window to get the CTPA done, you will get that done. And if that comes out to be positive, then you would continue with the therapeutic enoxaparin for 3 months, which would be reviewed at 3 months' time. However, if your CTPA come back as negative, then you revert back to the high dose, high prophylactic dose of low molecular weight heparin. So if you have any questions, if you have any doubts about this, we can always discuss it afterwards. But hopefully I've made myself a little clear. And the monitoring of this is done by anti-10A levels. So after the 4th dose of your low molecular weight heparin, we do the peak and the trough anti-10A levels. And based on that, I can go into the arbitrary cutoffs as well, but it depends on your reference lab. So anything between 0.5 to 1.2 is accepted, that fine, we're not going to change. But anything different from that, we will take opinion from hematology to say, okay, do we change it or not? So anti-10A levels is what's to be monitored. Okay, hope it's a bit clear. So just again, a bit off the clinical topic. So with regards to the communication on the intensive care unit, I think it's a very important point, because as much as you would want to speak to the nurses or doctors in there, you need to have a way of doing it. And we have kind of not got much telephones in there, because again, from an infection risk point of view, we have started using walkie-talkies, which are stationed over there outside. So we have these Motorola walkie-talkies, and we use that quite a lot. There are certain areas which we had to make shift into the COVID area. So in that, a wall has been built outside, which actually gives us an anti-room for the donning and doffing. So that's something, again, infrastructure-wise needs to be thought about. There's always a runner outside this COVID area who is not in full PPE, because there is a wall there, but from inside, any communication given that we need this drugs, we need this equipment, they will be immediately able to procure it. So that's the idea of having a runner outside the COVID ICU. We have a central and a slave monitor where we get a fair idea of what is happening with our sickest patients. So you can keep an eye on it. There are emergency buzzers in all areas. And please have utmost caution when you're doing any emergency procedures, and particularly CPR in these patients. The resus guidelines are pretty clear that you need to have appropriate personal protective equipment at whatever stage of resuscitation that you engage with these patients. So just be aware that yes, as doctors, as intensivists, as anesthetists, we can be quite passionate to jump in and try to save lives. But equally, this is a situation where you just need to be a little more restrained before you aggressively jump in. So just be aware of that. And coming to a bit of research, what we are involved in, I just want to briefly highlight what we are actually doing. So we are a part of the genomics trial. Genomics trial is basically we take blood samples, we do a profiling of these patients with regards to their demographics, and also try to build up a phenotypic model of patients who are on ICU or who are on the wards, and to see why they got sick to go on to the ICU, and if there is a pattern that can be recognized based purely on their demographics and their genotypes, to see if anything can be deduced as a result of that. So that's ongoing, that the blood gets sent to Bristol, and that's done. With regards to recovery trial, that's one of the largest trials going around in the United Kingdom. So we have more than 9,000 patients recruited into this. It is fairly straightforward. So you have one arm of it, which is the standard treatment. You get the standard intensive care treatment. Next, you have antivirals, lopinavir and ritonavir. You have low-dose corticosteroids. You have hydroxychloroquine, and you have the IL-6 blocker of tacrolimus as another arm. So basically, the randomization is an electronic process. So there are research nurses. Once any patient who's on the ICU would get randomized into that, we fill a questionnaire, and once you put all the details into the system, the computer comes up with an algorithm and will randomize the patient into a particular arm of the trial. So we are also a part of the ISURIC trial. ISURIC is basically a pandemic database collecting where we are getting a lot of information about what is the total number of patients who are positive, what are the number of patients who have died, who have recovered, the time spent in the hospital, time spent on intensive care unit, time from admission to hospital to come to ICU, non-invasive ventilation, invasive ventilation, and so on. So there is a huge amount of data that can be gathered from that. And again, you can kind of look at a certain pattern as well. As far as convalescent plasma, we are not at this point in time a part of any trial for that, but we are getting it as I speak from Monday onwards as a part of the Remap Cap trial. So Remap Cap trial is a very interesting trial. I would ask you all to read up if you want more information. It is freely available online. So remapcap.org and recovery.org is the website where you have a lot of detail. So it is interesting because it is randomized, embedded, multifactorial, adaptive trial. So just to simplify this, it is a trial where you are looking at community acquired pneumonia with a slant of the COVID-19 situation to this. So it uses Bayesian statistics as a part of the assessment of the results, which is based on an interpretation of probability. So to make it quite simple, you can have different arms of a trial with combination treatments. So a patient X can be on hydroxychloroquine, convalescent plasma. Patient Y could be on an antiviral and say low-dose steroids. So the importance is that every 300 patients there is interim analysis that is done, and following that there is a calculation of probability of either superiority, inferiority, or equivalence, and based on that there can be a modification of patients to be moved into the arm of the trial which is showing some results. So that's a very, I mean, I can go into the details, but I don't want to muddle the pictures in this presentation by telling about that in detail. So if you're interested, it's something which you could track into. Okay, so that's Remap Cap. And we're also part of the COVID track trial where we do the tracheostomy in these patients, and we look at what the outcome is to the point when they get decannulated. So indication for tracheostomy, how many days prior to them being intubated from a tracheostomy point of view, what were the PPE precautions taken? Was it a straightforward, difficult tracheostomy? Was it a surgical tracheostomy, percutaneous tracheostomy, and time to decannulation, time to leave the hospital as well. So we look into that. So just as I was mentioning, this is more about Remap Cap. So one of the important things is that anakinra is also a part of it. So I think there will be some possible direction of where this is going from a treatment morality point of view that we might get. But as of now, none of the trials currently in level 3 patients who are intubated and in multi-organ failure, there is any kind of mortality benefit. So coming to the shift out criteria, I mean, this is what our infection control and our microbiology team have agreed upon. So anyone who's in the hospital with us for 14 days from the first positive test, and there is absence of fever for at least 48 hours, and there is clinical improvement of that patient. When I say clinical improvement, if they're on the ventilator or if they are tracheed if they are down to 35% oxygen. It's again based on a clinical interpretation that we go by. Again, we discussed this with micro, but there should be some clinical improvement. They should be apyrexial for 48 hours. Then you send your first swab. So if that comes back as negative, you are good to do another test at 48 hours. Okay. So if that comes back as negative, then we step that patient down to the green area. Okay. So when I say green area, this patient is going to go into a non-COVID area. But again, all absolute precautions need to be taken, including the transfer trolley, bed, ventilator, and all of those things. However, if after that particular period of time, as I mentioned, with all those criteria met, if your first test is positive, then you have to wait for another 7 days to do the second test again. So that's the, I mean, and then it follows from that. So negative, wait for 48 hours. Second negative, going into green area. First test positive, then you wait for another 7 days. You do the second test after that. I mean, this is what our agreement is with our infection control. So with regards to, again, slightly changing tack from infection control, with communication with families and patient support, I think it's an absolutely necessary part. Sometimes I think we get lost so much in the clinical aspects of our daily work that this has reached a totally different level of communication is what we sometimes tend to forget. And bearing in mind, we don't have patient relatives coming into the hospital, certainly not into the COVID bay, because they'll all have to be mask tested, and they just wouldn't be able to come and see their loved ones. So what we have done is we have set a password for each family, because what we don't want is to end up calling, and if we don't have that password checked by the person who is going to be answering back, we don't talk to them, because there have been situations where people have just rung and found out what is what. So we have said that as a very basic, at least when we communicate with families. It happens on a daily basis. If it's not much of a big decision, then we leave it to the junior doctors. But otherwise, at least once in 72 hours, there is a consultant update that is done to the families. Apart from that, any major limitations of treatment or DNA CPR, we have a mini MDT in the afternoon where consultants sit together and make those decisions. In the tracheostomized patients and in the patients who have been extubated, we find that there is a lot of incidence of delirium. Again, it's quite obvious because of their duration of ventilation, benzos on board, unfamiliar environment, and obviously me with my respirator and all my PPE, perhaps looking like a demon, might be quite difficult for someone to recognize who this is. And with no family present there to hold their hands or anything, it becomes very challenging. So I've had a patient who's ripped his CPAP mask off because he just felt that he was somewhere in the jungle in Africa. So lots of things like that. So you need to be aware that there is going to be more and more of these problems with us using PPEs, which is a part of the treatment as we should be doing. So when someone has passed away as well, we have excellent support from bereavement services who get involved in speaking to the family, and also there is psychological support available as well. So as for a healthcare worker, I think we all are to be conscious of the cognitive overload. I think we all end up with a lot of cognitive overload, with a lot of decision-making processes that we get involved, not necessarily clinical, quite a lot of family discussions, which can be quite challenging. So we have got into what is effective team mode. So we have teams which work in particular bays, and we have a good rapport. And as I was mentioning, you need to offload some of your physical work to proning teams, for intubation teams, for transfer teams, and so on, just so that you don't get caught up doing everything by yourself and try to spin a lot of plates. So I think that's something which you need to be aware of, especially if you are going into a very high escalation state of affairs of your ICU. So team huddle is very important. The debrief is a good process. I'll tell you a little more about it in my next slide. And have a doctor buddy. It couldn't probably be an intensivist. It could be anybody who's a medical person. I mean, the reason why I say is that you could just talk. Look, I've had a quite a rubbish day. I tried this, but I still couldn't do anything. Just talking to somebody might be useful, even over a cup of coffee, and have a routine. And as much as I would say, uh, both at work and off work, it is important, because with the amount of fatigue that you can go through, you can easily make certain mistakes while you're doffing and so on, which will end up with you possibly getting yourself sicker. So with the uniform policy, with your food, with definitely having a shower before you come home in the hospital if you can, having comfort breaks, these are very important part of your routine. And off work as well, do something which will keep your mind off. I mean, I certainly come off social media at least twice in a week if I'm not working. I mean, I absolutely mute all my. I don't know. It's very challenging. Anup is smiling, but it is. Quite challenging, but it sometimes takes a lot of your head to just take some time off and do something which you genuinely want to do. So just coming back to the debrief, I think if you do have any kind of an untoward event, or someone dies, or someone um, some kind of event happens, I think you need to perhaps look at how you would want to do it. So why is it done, when is it done, and who does it? So I think why is fairly obvious, as I've mentioned. When, you could either do it at the end of that serious event or at the end of the shift. And who, I think, as consultants, as clinicians, we probably need to take ownership of that in kind of leading on the debrief and allowing people to talk. I think that's very important. Sometimes it can become a monologue. We can end up telling a lot of what we feel, but there can be very quiet nurses, even healthcare assistants, who have gone through a lot but don't feel like talking. So I think we need to encourage them. Uh, First, go through what the facts were, because sometimes going through the facts helps in people to understand everything has been done. It just wasn't what we could do. So facts is good. Recognize what it is, and it's sometimes to be told it's okay not to be okay. This is what it was, and this is what we had to do. So that's something which needs to be recognized, and ask people around if they want to share anything, and encourage them to not necessarily at work but off work also to uh, take care of themselves, and not to blame themselves going home carrying any baggage. And if despite that they need any support, any kind of a health and well-being offer that is there in the trust or in the hospital needs to be given. So just to summarize, I want to finish by saying that we need to be ready to accept the new normal. I think that's a mantra which we it's difficult for us to perhaps imbibe at a subconscious level, but I think the more and more we start accepting this as the new normal, it'll be more easier to move forward. And as intensivists, we need to do our basics right. I think sometimes people just get lost with the COVID era about your general intensive care. So you are doing what you are doing. It's a COVID patient, non-COVID patient. Do what you're doing, but with certain obvious caveats to these patients. So that is something which needs to be kept in mind. Definitely, what we have noticed, and of course all across the globe, is the sicker patients who are on the ventilator will obviously have quite a poorer outcome. So any strategies that would limit their coming to the ICU, which can be done at a more peripheral level, and of course apart from the lockdown, would be quite effective. That's what we have now started looking at, because the health economics, the resources involved in caring for the sickest of the sick with pretty much 70 to 80% mortality in multi-organ failure makes us think, should our energy be channelized in doing this on a broader scale outside ICU, and having ICU without walls, where you can catch these patients early, perhaps prevent the progression, and then limit them coming to ICU. At the moment, there are no any game changers or magic bullets. There's lots of work going in. We are in here for a very long haul, I would say. And I think we need to build resilience, not necessarily for ourselves, but for the entire team. And we just need to stay positive and move forward. So that's me in different phases of my life. I'm a singer. I play Radangam. I eat properly, if you see. Yeah. I do a bit of gardening, and that's my nurses, Andy and me there, having a bit of a dance pose. But yeah, thanks for your attention, and I'll take any questions from there. Thank you. That's my son, who's made a little poster for me, holding it out. So I love that. That's my screensaver as well. Thank you.
Thank you, Sudhindra, for your wonderful talk. Actually, we felt we have been taken through your ICU. Probably we were chasing you from your office, like the clerk's office, to the ICU, to the recovery room, even to your garden and your home. So that
Well,
was
I mean,
wonderful feeling.
thank you, thank you.
Okay, so we got to hear a lot about how actually at ground zero it's
Hmm.
happening in your place in UK, and we got quite a few people who are interested to interact with you. And actually,
Sure.
it was interesting. The initial request which came in our chat box was share your pathway to intensivist. Like, how did you land up in intensive care, and how did you reach
Yeah,
your present
many
post?
many people are asking the same question, Sudhi, like how you became a consultant in UK, because I think the people who are doing post graduation, they really wanted to know
Sure.
about opportunities in intensive care, I feel.
Sure. I mean, I can tell you more in detail about it because I'm one of the part of the medical training initiative persons in our trust as well. So I can give a little more detail. But talking about myself, I finished my MD in KMC and then did my neuroanesthesia fellowship at NIMHANS. And once I came here in 2010, I worked in Liverpool and then started doing all my postgraduate exams in anesthesia here. I applied for the rotation. So initially, first 2 years, I did my core training in anesthesia, which again opens up your branching, either going into anesthesia or into intensive care. So following that, I got the national training number in intensive care. So once I took that, if you're an anesthetist, you need to do medicine training, emergency medicine training. So uh, to summarize it, I must say that it's 8 years of training. So I went through that from 2010 onwards. So it's been quite extensive. In which case you rotate through pediatric intensive care, cardiac intensive care, neurocritical care. You also do a lot of your anesthesia advanced training as well. You uh, train in ultrasound, and once you have done that, you also need to do a management, pretty much like an MBA kind of a thing, so that you get quite rounded in your managerial skills as well with regards to your policies and guidelines and all that. So after that is when you get the CCT, and following that, and if you have gone through that all quite well, I had an option in 7 places. So 7 trusts across the Northwest wanted me to be employed. So I could choose where I wanted to go actually. So it opens up a lot of options. And if you are postgraduates over there, and if you've done your MD, and if you're doing your FNB and so that, it gives you a solid background to start your career. So if any of you have interest, and if you are interested in working here, I'll share my email with Sanish and Anup, and you're welcome to contact me.
Yeah, so Sudhindra, like excellent presentation, and again, very nice experience sharing. So few things like I wanted to know is like
Sure,
you told about this like thromboprophylaxis, and again the therapeutic dose of low molecular weight heparin.
sure.
During that, you were mentioning about anti-10A levels, looking at the trough value and the peak value. So
Yeah,
here in India, we don't have an anti-10A activity routinely monitored. We find
sure,
it a double dose, like either it has a once daily or a twice daily. So
sure.
like, can you just explain to our attendees once again how that anti-10A based low molecular weight dosing can be fine-tuned, and again, in your experience, like whether you have like observed any resistance with the double dose, something like enoxaparin when you use something like zero point 0.6 BD or 1.2 like OD when you use, like
Yeah,
did you observe any resistance? And in case if you observe that anti-10A values or trough values are not at the level you want, so how you proceed with that? Can you just
sure,
brief about those things,
sure,
COVID
sure.
related in general?
Yeah, yeah, yeah. So I think uh, specifically with regards to the high dose prophylactic, we are not too worried about the anti-10A levels, because these are patients who are on oxygen and who are on ICU and who have not had a huge change in their oxygen requirements, or have not shown an obvious sign of them having a PE. But our threshold has now changed simply because even when we did CTs on these patients just because they were not weaning from the ventilator. We have found out them to have incidental segmental and subsegmental PE, which has now changed our practice to CT them earlier. So
just one point, can I interrupt,
sure,
Sudhindra? Because
yeah,
I was also going through the many literature except the autopsy finding, and
yeah,
majority of places they found only the subsegmental PE.
yeah,
So can we take a subsegmental PE as a significant PE? Because like especially when lungs are so much consolidated, patient being
yeah,
hypertonic, there are previously also many papers like it's a radiological fallacy. You cannot
yeah,
take it as a like proper PE.
segment.
So what is
Hmm.
your comment on subsegmental PE in such
Yeah,
patients?
yeah.
And
I think
anti-10A and all those things. Yeah.
yeah, yeah. So yeah, with regards to the subsegmental Ps, again, we have that quite extensively discussed with the radiology team, and we also go by the clinical picture. I mean, if someone is quite unwell to the point that they are pretty much in refractory hypoxemia, and there is a huge issue from their ventilation point of view, then we don't hesitate to have them, unless there is no gross contraindication, to put them on therapeutic dose. But I agree with you, the report can sometimes be so box standard that subsegmental P cannot be ruled out. So what do you do with that is what the question comes up with. So what we have mentioned in our department meeting and in the policy is that if it cannot be ruled out, then given the current context, we would escalate them to therapeutic anticoagulation. And of course, in 7 to 10 days time, we would repeat CTPA depending on how the patient's condition is changing. With regards to the anti-10A levels, so anything between zero point 0.5 to 1.2 is what we accept to be in the therapeutic range with after the fourth dose. So if you're looking at the peak and the trough, okay. So with that, what we have also agreed with hematology is if it is 0.51 or 0.55, then we are not fussed about it. But if it is also in an 80-year-old man, we are looking at INR, I mean the 10A levels as 1.7, then it's something which we at least need to do a 25% dose reduction. So that is one thing which we are looking at. And also we go by the EGFR in patients with renal issues. So if it's less than 30, more than 30. So the bottom line to the question is, if you're looking at the 10A levels, based on it being a small deviation from the acceptable range of about 10%, we don't change, because it's quite difficult to adjust the dose. But if it is something grossly on the other end of the spectrum in a patient who is perhaps vulnerable from a bleeding point of view, in that case, we do a 25% dose reduction. To give you a simple example, someone who's 50 kilos, if you put them on the high prophylactic dose of 5,000 BD, that's what we are doing, 10,000 milligrams, I mean, 10,000 units of dolteparin is a therapeutic dose for a 51 kg man. So if I'm looking at that context, we need to look at in the context of the patient as well. So the 10A levels are useful, but if it's not being routinely monitored, what I would want to tell the attendees is that the agreement from hematology has been that this is in general a fairly safe dose, the high prophylactic dose. But if you're going to therapeutic dose, then if you're not able to monitor the 10A levels, you just need to be aware that there is a subsegment, I mean, so there's a cohort of patients who are going to be more higher risk from a bleeding point of view.
Okay. Then regarding that COVID track trial you were mentioning, no? So
Yeah,
what is your consensus there regarding the tracheostomy? You forget about the trial per se. Like
yeah,
when you consider doing a tracheostomy, you go for an early tracheostomy or late tracheostomy? Because the previously when I was going through the NHS guidelines, there was some recommendation you delay the tracheostomy and don't go for like if it is not really indicated. So sometimes
yeah,
we go for early trachees in some ARDS patients whom you like feel that will require a prolonged ventilation. So
sure.
what is your like take on that?
I mean, I've performed personally 9 tracheostomies. I mean, in COVID patients, but our database extends anywhere to around 35 to 40 kind of a thing. So, if our general trend has been that we perform tracheostomies quite later in the disease. The reason why I'm saying is that in the early part, they are quite unstable. If you're looking at it, they move from perhaps the L to the H phenotype, and there can be patients who are on very high amounts of oxygen with a PF ratio barely acceptable. So we don't know whether they will get really unwell when you try to perform a tracheostomy in these patients. That's point number one. Second is, we don't really know what the pathophysiology is and how it is going to trend in a week or so, unless we have them stable to the point that we are fairly certain that they would cross the bridge. That's when we embark on a tracheostomy procedure. Because another important thing, again, it's more from a family point of view as well. I think if when you mention tracheostomy and those things from a family's point of view, it is taken as a very positive hope kind of a situation. So we do bear in mind that when you do discuss to the family about a tracheostomy, that we are reasonably reassured that, okay, this person is making some recovery. Because if they can be tube tolerant in the early part of the disease and there's no reason to perform an early tracheostomy, we would avoid it. So certainly I have done tracheostomies on day 17, day 22, and 5 of them have got decannulated. 3 are still on the unit but are getting weaned.
Okay. Next thing is like you are mentioning about the low dose dexamethasone, no? So how low the low dose dexamethasone will be?
As a part of the trial, we are on 4 milligrams TDS for 10 days.
4 milligram TDS for 10 days. Okay.
Yeah, that is a part of the trial that we're using. And as a routine steroids for early ARDS, we are not using, because it's pretty much every patient who is in ventilated is on the recovery trial. So we are not skewing our results by having patients on steroids.
And many people are asking about the fungal infection incidence. Like you might have seen the more like aspergillosis in patients with COVID. What is your experience in your center, like especially fungal pneumonias?
Again, we have twice weekly cultures routinely sent from the ICU. So we haven't had that much of an incidence among these patients that we have had to have a fungemia or aspergillosis as such, which needs very aggressive treatment. I mean, what we do procalcitonin for our bacterial infections. As far as the beta-D-glucan and the other galactomannan levels that we have been looking at, it doesn't seem to give me a trajectory to say that these patients are more vulnerable or more at risk from a fungal pneumonia point of view. What we do tend to do is the PCT is quite sensitive in what we are following, and it is giving us a very strong idea of when to de-escalate antibiotics. And we also see that surprisingly, CRP is not what correlates well with the patient's inflammatory markers. PCT is what is looking to be quite sensitive.
One of our attendees wanted to ask something. Like
Sure.
you can unmute and ask. I have promoted one of you who raised the hand, Galaxy S10e. So if you want to ask something to our speaker or to the panelist, please unmute yourself and continue. No, I think accidentally they might have raised the hand.
All right.
So,
Okay.
other question was again the questions in the Q&A.
Sure.
You are asking, like, as you are well aware, the CRRT is not very common in Indian ICUs. We hardly do CRRT because of the cost constraints itself. Majority of the time we go with the SLED, and again we usually don't go for ALE, SLED or CRRT. Maximum like severe refractory acidosis or like electrolyte imbalance. Those are the indications, or the patient continue to be anuric with worsening acidosis. So those are the usual indications for which we start CRRT or SLED. So in your unit, or like especially in UK, what is the practice? Do you start early like CRRT, or even for the fluid removal purpose? Like if you are not getting adequate fluid balance, will you go for early CRRT? And again, how will you continue that? Can you just explain that to our attendees?
Sure. Again, the practice is pretty much very similar to what you're saying. I mean, we don't go for early CRRT purely from a fluid point of view. I mean, we go with any indication which would be acidosis. I mean, any acute indications, obviously you would go for it straight away. But With regards to the COVID patients per se, if you have to give you a bit more of a perspective, what we are finding is that these patients do have a certain period where their kidney functions get quite poorly, but it's no indication for them to go on to renal replacement. So, as such, unless there is a clear reason to believe that they've got oligoanuric and they have the KDIGO criteria met to go on for renal replacement, only then we would do it. I mean, we do hemodialysis on our unit, but if I have to talk about CVVH, a couple of our sister institutions do that, but the practice is pretty much the same. We don't go for early renal replacement unless there is a clear indication. And also bearing in mind, you need to have your logistics of cost implications about how you can use it if you have 20-25 patients who need renal replacement with regards to your disposable equipment as well. I mean, that's something, if you have a policy where your thresholds have changed, then you will end up doing a lot of things which then you'll have to recalibrate yourself. So you just need to have that clear from that point of view. Hope that answers it.
Yeah. And one more thing, Sudhindra, now in India, especially in Kerala, the main discussion is like regarding the travelers returning from Gulf countries and abroad, like mainly
Yeah,
from COVID affected areas. So
yeah.
here in Kerala, what the government decided is to keep them in quarantine homes for 1 week, do an antibody or like a PCR test depending on the availability, then
Mm-hmm.
send home for 7 days quarantine in home. So even
So
that
total
was
14 days.
a
Yeah,
total
total
14
of
days.
14.
Yeah, even that was extensively criticized here in Kerala because people are not taking 14 days. So when I was talking to many intensivists and friends in UK, so what they are saying is even when the doctors are tested positive, if they are mildly symptomatic only, they send home saying that you self-isolate. So can you just explain the policy, what is
Yeah,
interpreted there?
sure. So I think the two important things to mention to you is, I'll just give you a simple example. So if I become symptomatic, so if I have high grade temperature, if I have sore throat, or if I have a continuous cough, then I'll have to report to my line manager, who's the clinical director, to say, look, I am having these symptoms. So then I'm put on a list of, because I'm a key worker, I mean, all the healthcare professionals, police officers, all of these, you're put on a list of people who will get swabbed sooner. I mean, it could be 6 hours, it could be 8 hours, depending. So once I get swabbed, I just tell the department that I am in self-isolation. Okay. So I come home, I wait for the results. So if my results come back as negative, I'll go straight back into work. Okay. Provided I'm asymptomatic. So I should still remain asymptomatic. So if my result comes back as positive, I have to wait for a week, and following that, I'll have to see if I'm still having symptoms or not. So if I'm come back as positive and after a week I'm asymptomatic, then I can go for work. Okay,
Even after
but
1 week,
1 week, yeah, yeah, yeah.
you don't have to do a
Whereas
repeat testing.
no, we don't do a repeat testing. So, but if at home one of my family member is having symptoms, then I'll also have to isolate, and that family member needs to be tested. Okay, so if they come back as positive, then I'll have to self isolate for 14 days.
Okay.
So, understanding what I'm,
Yeah,
because
yeah.
that will be the starting point, kind of a thing.
Okay, fine, fine, fine.
Yeah, yeah,
And
yeah.
your
So
are you people are doing antibody test or only PCR test?
no, only PCR test,
Okay.
no antibodies.
And again, like here in ICUs, like some of the centers are having these point of care chip-based PCR test where you can get the result within 1 hour, and whenever you get a patient in the ICU to do that test and get the result immediately in the unit itself. So it's
Yeah,
very easy for you to triage the patients. Do you have
yeah.
any such quicker PCR test there? No.
No, we don't. We are just use standard lab test is what we are
So
relying. We get it
how
within 4 hours. 4 hours.
4 hours? Okay,
Yeah.
because
So
you're
we put them all in the amber bay,
uh,
and based on that, we once we get the results, they are either shipped out. But bearing in mind, Anup, I'm sure you've experienced this, and lots of the attendees, there is a slight disparity between the test and the clinical picture. I mean, we find that patients can be really having the features of COVID, but their swabs can be negative. So please bear in mind that that has to be still. We have a clinical discretion where I have put patients in the red zone, and they have turned out to be COVID, but initial test was negative. So you just need to bear that in mind, that you don't send them into green purely based on one point of care test. So that's something which everybody in the audience need to be aware of. Yeah.
And again, one more doubt regarding the same related to the same.
Sure.
Like, suppose you do a like you suspect something like a viral pneumonia or COVID. The COVID PCR came negative. Will you go for something like a pan PCR or something like a biofire for looking at different other viruses, especially? So, what is your policy on that?
So we routinely check for influenza A, B, and RSV, which is a part of it. So along with the COVID, we also, I mean, coronavirus, we also send for this.
So
So
you
if they come,
send all the four together, not that one.
yeah.
Excellent, yeah.
So we send that, and if they come back as negative and if they come positive for that, we would still repeat the second one on this, because it can be coexistent. So it's not like one doesn't exist with the other kind of a thing. So
Doctor,
you would repeat it.
yeah, Dr. Amrinder want to ask something. Dr. Amrinder, you can
Sure.
unmute and ask. Dr. Amrinder, are you there? You can unmute yourself, then you can ask. Okay, that's fine. Okay, the rejoining policy is also the same, no? As you have already told, if completely
Yeah.
asymptomatic. Okay, and many people are asking, like like the pattern described from Wuhan is something like when the symptoms started on say by about 9th or 10th day, you became like more sick, like landed up in the hospital, and by about 12th or 13th day, the patient will be in the ICU. So what is the pattern you are observing in UK now? The same pattern or it's a different?
It's pretty much the same pattern, but one important thing what I want to highlight is that uh, between patients who end up on ICU and between who patients who rock up to the acute medical unit or respiratory ward, there needs to be better communication among the teams, because what we don't want is someone who's on high amounts of oxygen, either high flows or CPAP, for a prolonged period of time, in which case them, rather than having their work of breathing increase and their lungs changing from the L to the H phenotype, arguably, you want to catch them early. So it's very difficult to say when that transition happens, but the general trend that we are seeing is that if they present early and they end up on the ventilator in the early stage of their disease, they seem to do rather well, rather than someone who's presented quite late, who's been flogged with other means of ventilation for a good 3 or 4 days, and then if they end up on ICU and then they get tubed, they pretty much have a 100% mortality.
Yes, Anish sir, there are again some more questions. And friends, I have to leave for one another meeting. So you can just, I think, finish the questions and then we will come back again. Like Dr. Sudhindra will
Right.
be with us again with his experience in critical care and again COVID-related new issues, updates, etc. Okay, thank
Right.
you.
Nice catching up with you, Anup.
And,
Take care.
yeah,
Have a good evening.
Anish
See
will
you. Bye.
continue. Thank you.
Can you,
Sure. Bye. Bye.
you
Bye.
need to make me co-host now.
Yeah, please. Yeah.
Okay, fine. So there were some other interesting queries, like what
Sure.
kind of mask, like the mask you showed in the photograph
Mm-hmm.
as
So
part of your
okay,
PPE.
I can tell you that. So basically, we have there are practice educators who do the mask fit for all the healthcare professionals. Pretty much everyone who works in the acute environment. That includes acute medics, respiratory surgeons. I mean, anyone who is going to get exposed in a COVID environment. So we have, apart from the respirator, the FFP3 masks. So the way it is working is, it the manufacturer and the scale in which we get changes. So unfortunately, every time there is a new set that comes, people will have to be fit tested again. Okay, I am lucky in a way, paradoxically, that I failed the FFP3 and I've got the respirator. So the respirator is pretty much mine. So I have to use Clenil wipes and clean it, and every time I have to use it, I will just put that on and use it. Whereas uh, many of my colleagues use the disposable mask. So the answer to the question is yes, there are stringent fit testing procedures. You're put into a hood, and then there is a spray that is put through a little hole in that hood, and you're asked to do different maneuvers for 30 seconds. So you move your head right and left, you talk, you breathe, you take deep breaths, you cough, and then you have to actually feel the bitterness of that particular taste at the back of your throat. So if you start feeling that with the first or the second puff itself, then you've failed that test, because it's transferred all across from the holes or the sides anywhere which is porous, and you have failed the test. But if you don't feel that bitterness, but if you do feel it much later in the part of the test, that is fine. So that's how the test works.
Okay. Can you show the mask, your respirator once again from your slides?
Okay, sure. Should I go to screen share? Is it? Yeah.
Yeah.
Okay.
Yeah. Okay.
Yeah, that's. I mean, in the top left hand corner. I mean, that I put my name because with us, 50 of us, I think we need to have our clear names on it. And so if you look on the sides, these are the filters. Okay, these last an entire pandemic. So the 3M is the manufacturer of this. So the filters on the side fit onto them, and the external surface is what needs to be given a good clean. So the idea is you take the filters out, and then you keep it on a clean cleanliness surface, and then you wipe them for at least 30 seconds after you come out. So again, if you look at me here, I'm donned here to go in. So once you're in there, you need to make a visual assessment of yourself that, okay, you've got the hat on, you've got the visor on. I have glasses, so I have to put that on, and then the visor comes on. Then you have your, again, depending on where you are and what kind of equipment is available, all you need is a water repellent long sleeved gown. That is the most important thing that you need to have. Okay, so after that you wear gloves over it, and we put a bit of tape so that the first pair of gloves remain and it doesn't come off the sleeve. So you put a bit of tape around it, and you leave a little bit of it exposed so that you can easily take it off. And then once you're inside, at the individual bed space, you wear a pinny, and then you wear an extra pair of gloves over it. You change the vent settings, you do your echo, you do your lung ultrasound, you prescribe whatever you have to. And once you have had contact with the patient over there, you come back, you take your outside gloves, you take your pinny off, and then you again alcohol gel your gloves, which is there, the first pair of gloves. So that acts as your first protective layer. So once you have done that, you move to the next bed space, and then have your next fresh penny on, and then the other pair of gloves to deal with the next patient. So that's how you do your ward rounds. And then when you are finally about to leave, so you still have your gloves with the alcohol gel on it. So you take the hat off, and then what you tend to do is you need to rip your water resistant gown from behind, and as much as possible try to fold it so that you're only touching the inner side rather than the outer side. Okay, so once you've done that, your gloves comes off with that, and once you have put it in there, you again wash your hands, gel your hands, and once you're out, your visor, and the last one to come out is your respirator.
Okay. And again, how is your duty schedule? Like how long you work your duration?
This is slightly in contradiction to quite a few of my Indian colleagues who are saying that 4 to 6 hour shifts is what they're doing. They're saying, but I just feel that they probably are always in the COVID area for those 6 hours. But for me, we work. I do a 15-hour shift, which is like starts at 8 o'clock in the morning and then finishes at 9 in the night. So when I'm on, we don't have any more short days or standard days. We are either days or nights. So all our ICU consultants are either days or nights. So I do those shifts. If I do 3 shifts, then I'm off for another 2 or 3 days, depending, so that I can reduce my viral load, risk of exposure, and also I'm basically off from a COVID thinking process. it's a bit like working in a nuclear reactor. The more you are in there, your chances probably are a bit higher. So we make sure that your number of days are lesser, but you are in there in the ICU more. But as I mentioned in my presentation, we don't spend much time in unless you really have to do something. That is a very important point.
So you get enough time for your coffee breaks and
yeah. And with the plans made, we do the ward rounds in the morning, come out, and then there is proning. We decide who needs to be proned, what is the PF ratio, what is the cutoff. So again, that's another thing. If the audience want to know about it, you need to make a plan by mid morning about who are the potential ones who you want to prone, because what you don't want is a patient getting really sick at 2 o'clock in the morning, and then you have to prone this patient. So if your FiO2 is trending to more than 60%, if your PF ratio is trying to get from moderate to pretty much severe kind of ARDS, and if they none of your recruitment maneuvers using of your PV tool has made a difference in that particular time, then you have to make a binary decision that you want to prone these patients for what it's worth by around 4 o'clock. I think that's another important thing you need to decide, rather than leaving a 50-50 chance of let me see if it goes or not kind of a thing. So that's something to keep in mind.
Again, as you mentioned, the same team proceeding with airway intervention, initiating mechanical ventilation, finishes off with definite venous access and other devices insertion in the same sitting.
Yeah, absolutely. So I think that is something which is a really useful thing, because it makes it a lot more, it saves your, I mean, we were in a zone where we had to save PPEs as well. People were just going in every now and then and coming. So that one person popping an NG central line and intubating is 3 procedures done. Imagine if it has to be done by 3 different people. And equally, you also need the most senior person in the first pass to do this procedure. What you don't want is someone who's not, it's not a teaching modality at that point in time. So you want first pass straightforward intubation, you want a first pass hopefully straightforward line, and also to have your NG inserted so that you can start enteral feeding as soon as possible. So that's something which is worked really effectively.
Okay. One more thing, you mentioned about taking back diazepam and long-acting sedatives and all back to our analgesia sedation regimen. So would you recommend this for our non-COVID patients also, so that the people working in ICU will still be in touch with the pharmacokinetic dynamics and duration kind of thing, so that in case of a surge, future surge, may not be in COVID or any other surge or any unanticipated pharmacy crisis, they'll be more comfortably switching over to these long-acting things?
Absolutely. I think that's a very valid point. I think any kind of enteral route that can be utilized for reducing sedation is a good way forward. The only sometimes the problem is if they are on a fair amount of vasopressors, if they have ileus, you're not quite sure about the bioavailability via the enteral route of some of these medications. Having said that, you can still use IV route for the oxycodone or morphine sulfate, or the diazepam can be given IV as boluses as well. So you can still rely on it. But again, the answer to your question is yes, using enteral route early. Like we use clonidine as one of our agents to wean patients off their sedative agent. So we started quite early. Anywhere we go up from 50 mics to 200 mics QDS dose. We don't go for an infusion. So we have alpha 2 agonists introduced fairly early just to bridge us over from their weaning regime point of view. But yeah, long-acting agents introduced early in a non-COVID environment also is a very effective way of weaning sedation.
I'll try to take some questions. One participant, Galaxy S5, you have raised your hand. Can you unmute and talk? Because your name is not mentioned in the username. Dr. Amarinder, you're with us?
Yes, sir.
Yeah, you can go ahead with your question.
Yeah. Sir, it was a very nice presentation. I must
thank you.
congratulate you.
Thank
Sir,
you.
I have rather a very clinical question, not
Sure.
ICU. Yeah. Uh, in a patient who has otherwise a compensated heart failure, suddenly got decompensated, would you like to go for COVID testing, sir?
In what context, Amrinder? I mean, are you talking? Is he in the ward or is he in the ICU? I mean, I just to the answer to your question, any change in the patient's cardiovascular physiology would be a good enough reason. So yeah, go on. You were telling something.
Yeah, sir. So if any patient comes to us, sir, in emergency with a decompensated heart failure, sir, otherwise compensated chronic heart failure, should we do COVID testing in that patient, sir?
Okay, but has he got any symptoms related to COVID you're reckoning? I mean, is there an element of temperature, sore throat, any of those things? That's first thing. I'll answer your question. Nothing.
Yeah, nothing, sir, nothing.
Okay, so yeah, the question is very valid and relevant because I think COVID is now in the community. Okay, so you cannot tease out one from the other in terms of what could be the reason for the decompensation. I mean, quite a few. I mean, in the younger lot of patients, they present with myocarditis as a presentation, so they can have a sudden change in their cardiovascular physiology and their cardiac status. So whether that is a contributory factor to that, or whether their lung mechanics have changed to the point that they've gone from a stable compensated heart failure to a decompensation, could be a trigger for you to test them. I would test the patient.
Okay, right, sir. So threshold should be low in these cases.
Threshold should definitely be low for these patients, because anything to simply give you an example, what I'm telling you, a patient with a GCS less than 8 who can't give a clear history, found collapsed in the street, who is brought into the emergency department, will get tested and put into the amber zone. Okay. The patient ends up going to theater, has whatever stabilization procedure and all of those things done, but we wait for that patient to be in an amber zone till we get a reason to believe that they are negative, and then being the risk being quite low, only then we shift them into the green zone. So it's better to be safe than sorry, because what you don't want is to have a positive result with you not being prepared for it.
Right, sir. Right. Thank you, sir. Thank you.
Okay.
No problem.
Thank you, Amrinder. I think yesterday when we discussed, Dr. Sudhindra, like we were discussing, people are actually concerned with what the emotional trauma the patient family they are going through. Actually, the healthcare workers per se, they also go through an emotional stress kind of thing.
Absolutely.
How do you motivate your supporting staff inside your ICU?
Yeah, that's a very important question. I mean, first of all, from a family point of view, we do use FaceTime, and again, we document that in the patient communication that patient's family, the next of kin, has agreed for seeing the patient on ICU. Again, this is agreed from a trust point of view, so that sometimes helps in them to have a bit more insight of how the patient is, because when you explain multi-organ failure and these kind of things, as much as you would, the important thing we need to remember is families hook on to the positives of every part of your discussion. More importantly, when it's not face to face. So you tell something on the phone, they only cling on to, right, he's doing better. So it's very difficult to translate poor prognosis and futility to a family on the phone. So it's very challenging, but it needs to be a constant reinforcement on a daily basis to make them clear about it. So that's from a family's perspective, but it is difficult. I've gone through withdrawal process with the family, and it was quite a traumatizing experience to talk to the wife about the whole process. She needed support. The family were elsewhere. They had to. The daughter was elsewhere, so she came home. They were all in self-isolation. So it's a very, very difficult situation. Uh, as far as the staff is concerned, it is very challenging. I mean, we've had uh, events in the ICU itself on the days, like there has been food that has been donated by quite a lot of local restaurants, and local community have brought in sort of processed food for us, which we have used and enjoyed basically. As far as the team is concerned, I, as a consultant, I'm responsible for keeping the atmosphere light in my team. I just need to make sure, are you doing okay? How are things? You just need to gauge and understand if someone is having a bit of a bad day. Like, I really feel for the nurses who spend 4 to 6 hours with the patient who's the sickest, and they are the ones who need the most support. So we just make sure that the health and well-being aspects of that is taken care of, and we have a debrief at the end of each shift where we just think, so is there anything you want to talk about? Having said that, many are in a situation where first it was very challenging, but now the new normal has become a bit more accepting of people. You go through different phases. There's a bit of frustration, there's a bit of unsettled situation, but after that, there is a certain degree of settlement that happens. So I guess that's what we have reached. Plus, we are doing a fair amount of fundraiser as well, hoping that after all this is over, we'll have a big get together. So that's the incentive people are working on.
Okay, fine. Because of shortage of time, we'll
Sure.
conclude with how you unwind, because we know you have different hobbies. You're singing, your mridangam and all. We'll wind up on a finer note, lighter note.
Sure. Yeah. Again, it's just not me. Quite a few of the colleagues of mine, I have seen that you need to have some kind of an exit strategy from your professional to your personal life.
You can
So,
put that
and
slide also, Sudhi,
sure.
so that message will be imprinted. Yeah,
So
fine.
it's thank you, because it's quite important. I mean, we all are doing a very stressful job. I mean, as much as the society and the community understands it, at the end of the day, your health and well-being is of paramount importance, not only from your professional life point of view, but also from your personal life point of view. I mean, you have a family who is dependent on you. Arguably, you have a wife and kids who look forward for you, and if you have to take care of yourself, that is when you will be able to perform to the highest level of your professional and personal life. So I take that very seriously. So if I'm at work, I'm 100% at work. But if I'm off, I use time in a very productive way as best as I can. Of course, um, it's not that it should become regimental. It's not like you are in an army to do this or that. It just goes by your passion. Some people just enjoy reading books. Some people just enjoy a lot of Netflix. I have a friend of mine who's pretty much every series on Netflix is on. But personally, I'm not a big fan of sitting in front of television. But there are ways of unwinding, and I have got a fine balance here. Now, after finishing this, I'm going to go for a run. So the weather is looking pretty. I'm going to run a 10K after this. So I run fairly frequently, and it is good. It's good from your exercise point of view. It gives you a time where you listen to some music, you unwind, and you just don't think of anything. So that's important. I do a bit of cooking. That helps a lot. Uh, and with regards to the musical instrument, it just gives me a bit more of focus to do something where I can concentrate. So that also helps me a lot. I mean, these are things which I've learned very early in my life, and I'm really lucky that initially I used to struggle. My parents have put me through this and all that, but now I feel it was a really useful thing to learn a few hobbies which have now become quite useful in this time. So take care of yourself, and if you do have anything that you want to genuinely pursue in your free time, please do, because this is a very difficult situation. And rather than being pessimistic or negative or thinking when is this going to be over kind of a thing, you would probably be better off adjusting yourself to this new normal and moving forward with it.
Okay, that was, we had a wonderful time with you
Thank you,
from
Sanish.
joining us from United Kingdom. And we had a good discussion right from the protocols, core intensive care, up to unwinding yourself. All these extremes, the spectrum was nice. The coverage was nice. We really enjoyed having you with us. So
Thank you,
looking
Sanish. The
forward
pleasure
to
is mine too.
having you with more critical care topic. We'll go for a specific topic and back.
Sure.
But right now, we are all interested to know how it happens in your place. Okay,
Sure.
thanks very much for joining.
Thanks a lot, Sanish. And in the future, as I said, I'll come up with more. I mean, I think I've tried my best to give a broad overview, but I'm more into niche. So if you want me specifically for specific topics, I'll come up with evidence-based discussion, which we can have more meaty discussions about. So I think I look forward for that with you and Anup in the future, Sanish. So we'll do that. And
sure.
Thank you everybody for being a part of this webinar. And thanks, Sanish, for having me. Thank you.
Okay, thank you. Our webinar campus, our motto is to create an academic platform and bringing prospective faculty like you. So we look forward to seeing you in further sessions. Okay,
Yeah,
thank you everybody.
Take care.
It's time to leave.
Thank you.
Thanks.
Thank you.
Take care.
Bye.
Stay safe. Bye.
Thank you.